The Honest Psychiatrist. Episode 2.
First of all, thank you for this interview. What is your profession based on?
In psychiatry, we work blindly, today as in the days of lobotomies. Suppression of symptoms is primarily considered rather than individual well-being and integrity.
What do you mean, sorry?
Well, there is a long discourse on the treatment of psychosis, but now let's talk about something that can easily concern us all. No exam shows us that there is a certain imbalance of monoamine neurotransmitters in patients' brains to determine their depressed mood or anxiety. But to simplify and prescribe, I tell them that they are depressed because they have too low levels of serotonin, the happiness molecule, in their brain, and that they need to rebalance their serotonin levels with an SSRI, just as a diabetic needs insulin.
And people come to you of their own free will?
We psychiatrists have on our side the rather common view that as doctors we have expertise in the pharmacological treatments we prescribe. People who are suffering and fragile clearly need to rely on competent people to give them security, doctors, in this case psychiatrists. These people rely on us without realizing that we prescribe drugs without knowing whether they are really necessary in their case, without knowing what effect they will have on individuals, and without knowing the myriad harmful effects they will have on their bodies.
Has anyone expressed doubts?
To those who express concerns about taking antidepressants, the big catchphrase in psychiatry reads, "Would you take insulin away from a diabetic?" This is a convenient gimmick that psychiatrists use to manipulate people who rely on them and rightly know nothing about psychiatric drugs or the nervous system. They silence any legitimate concerns by using such pitfalls. This is what those who work for the sale of psychotropic drugs do, who do not know if and when they help, who do not know what effect they will have on the person, and whose damage will be conveniently denied and masqueraded as mental illness.
Is it so out of control?
We psychiatrists simplify and trivialize in order to prescribe psychotropic drugs, and most patients rely on us and to not inform themselves further. But even as we inform ourselves, science itself today has enormous limits to knowledge about the effects of psychotropic drugs on individuals. The truth is that taking psychotropic drugs, accepting risk, is a bit like playing Russian roulette with your health. The reassuring concept that, if the drug gives you unwanted effects, you can always change the molecule, is not always valid either, because for some people and in an unpredictable way is enough to take a psychotropic drug, even just a few doses, to run into permanent problems.
Shouldn't patients be informed?
It is usual to explain to patients that in case of undesired effects of SSRIs and SNRIs, it is always possible to change molecule until finding the most suitable one. It is never mentioned that it is sufficient to have taken a few doses of an antidepressant to risk permanent iatrogenic damage, and not even admitted.
I can imagine why.
Yeah, I could not prescribe drugs after terrorizing a patient by informing them of the risks. I myself prefer to gloss over the risks. You have to think positive or you no longer live. Many of my patients report and show that they are better off thanks to SSRI and SNRI antidepressants. Those who worsen their condition because of the drugs, and who report that they have been damaged, I prefer to argue that the drug has absolutely nothing to do with, but it is unfortunately their psychiatric pathology that is difficult to treat. This way I can live peacefully and continue to prescribe.
Hiding the risks I understand, but how can you deny the damage done?
You know, psychosomatization, autosuggestion, paranoia. If you want, you can throw every symptom into the psychological dustbin. The damage of psychotropic drugs can easily be disguised as symptoms of psychiatric illness as well, the withdrawal symptoms, for which to prescribe more psychotropic drugs, in a fabulous loop for pharmaceutical companies and for those who, like me, base their work on the prescription of drugs that you do not know what effect they will have on individuals.
So, omerta and deception.
Of course, I can't be stupid enough to admit that the antidepressant I prescribed without warning you about the possible risks has caused you permanent damage. After all, the damage is done and I don't have a real solution for you.
Can you give me a concrete example?
As in the case of post-SSRI sexual dysfunction, until it will be based on patient testimony and not supported by biological evidence, I can consider it ambiguous and not pay attention to the patient's words. I can consider the psychiatric patient unreliable right from the start. I can afford not to care about the truth in what he says and think about my own convenience.
Today's psychiatry is not such a pretty picture.
Well, we can always hope that in the coming decades science will make dignified progress in understanding the nervous system and individual responses on a genetic basis, so that the treatments available will not consist essentially of trial and error made with horrible risks on the basis of mere hypothesis, and so that today's psychotropic drugs can be considered with the same horror with which we see the lobotomies of the 1940s.